Hello, and welcome to your online lecture for the Sacroiliac Joint Pathologies. This is the final lecture of this class. Some of you are celebrating. Well, I'm over here sad at my desk, tearing up just a little tiny bit. But what it means to me as a professor of this course is you are officially lower extremity specialists. So that means you should be able to, I said should, be able to evaluate anything from the pelvis all the way down. The reason I saved this lecture for last is because then you move into upper extremity where you begin in the lumbar spine. So you'll just progress onwardly until you finish in the fingers and hand in the upper extremity evaluation course. So without further ado, let's go ahead and start here. I like to start this lecture here. In the anatomy lecture, which if you haven't watched or if you watched really quickly, I would go back and rewatch again before listening to this lecture. I talked about how the SI joint does move. Even though that movement is very small, it does move about 2 to 4 millimeters, right? So let's think about that holistically. We've talked a lot about arthrokinematics versus osteokinematics, right? And if we were to define arthrokinematics, we would say it's small, subtle movements that occur between bones that you cannot physiologically see. Then there's these osteokinematic movements that occur that are larger gross movements that we can see, like flexion and extension, right? So when we think about the SI joint, what we're really thinking about is that those small movements are orthokinematic motions that we can't see, which lead to the production of movement at the trunk, right? So trunk flexion would be an example, or trunk extension would be another example. We'd have trunk rotation, right? So those small movements, even though they're very, very, very small, if we can just agree that there is movement, number one, and that because there is movement, that it can lead to pathology, it can lead to dysfunction, it can lead to immobility or the joint becoming stuck, then I think we'll all get something out of this particular lecture today. So what are some of the causes of an SI joint dysfunction? One of the common causes of an SI joint dysfunction is a bony cause. And this is something that we as clinicians typically can't do much about in the clinical setting, if that makes sense. So most often this patient is either born with a longer limb or a shorter limb, right? So they either have a longer femur or a longer tibiae, or they have the opposite of that. They have a shorter femur and a shorter tibiae. And most often these patients know, usually within the first year or two of life, as they start to walk and become upright infants or toddlers, it's usually diagnosed relatively early on. So these individuals substitute by either having a heel lift on the shorter limb, right, if that makes sense, to lengthen that limb out and equal itself out, or the opposite. If the limb is longer, then they'll put the heel lift in the other limb, right? So usually there's some type of prosthetic or orthotic that's placed in that patient's shoe, or typically they'll buy a shoe that sits a little bit higher when you compare it to the other side. So there are accommodations that these patients typically make. The hard part is when you have a patient who's participating in sport and let's say those shoe accommodations just aren't available. So how do we fix that? How do we compensate for that? One of the ways that we can compensate for that is actually sliding a heel lift into that patient's shoe. But you have to know that your patient has this structural leg length discrepancy, right? One way to assess the structural leg length discrepancy, as illustrated in this image here, is from that ASIS all the way down to that medial malleolus. And we will do that in lab if we haven't already. It becomes important to actually get good at measuring that. And so right now what we're talking about is a structural leg length discrepancy. When we get to muscular causes, we'll talk about a functional leg length discrepancy. But when we're thinking bony causes, most often the bony cause is a leg length discrepancy that most often is structurally related. And again, there's not much that we can do about that. The only thing we can do is if it hasn't been diagnosed in childhood and they get to you, then being able to recognize that, being able to refer out to typically a podiatrist to help resolve the leg length discrepancy, right? Okay. Next, we have muscular causes. And so you're going to see a few anatomical slides kind of pop up on the screen. Okay, you guys? So here's some of the muscular causes of an SI joint dysfunction. So what we know about the SI joint is about 45 muscles attached to the pelvis, the pubis bone, or the ischium, right? And so that's a 45 different reasons or causes for an SI joint dysfunction. If that doesn't make you uncomfortable, certainly makes me uncomfortable when a patient walks in with an SI joint dysfunction. So with that said, when we're looking at the posterior aspect of the spine, the iliocostalis, the longissimus, right? You guys remember those? The I love spaghetti, iliocostalis, the longissimus, and the multifidus, right? Are you guys getting that? Those are all muscles that can cause dysfunction at the SI joint. In particular, if they're tight, typically what we'll see is they'll tug on the SI joint, and they'll actually cause a posterior tilt of the pelvis if they're really, really or extremely tight. Similarly, on the posterior aspect, the glute medius can tug on the sacrum, and it can actually lead to inward flares of the sacrum by pulling that PSIS away from the spine. So we can see how the posterior musculature can play a major role in the way in which the ilium is moving or the way in which the SI joint is moving. But knowing how these muscles work, right? Knowing their concentric and eccentric actions becomes extremely important, which is why I always say anatomy is our foundation. We need our anatomy for much more than just evaluation. It's all about knowing what is causing and what happens if it's tight or if it's lengthened. Anteriorly at the thorax, we have the iliopsoas, right, or what we would call is the psoas muscle and the iliacus muscle. And we know if those are tight, they will also cause an anterior rotation at the pelvis, right? So just knowing that, right? Knowing if my psoas is tight, most often it's going to tug that ASIS downward and pull it into an anteriorly rotated position. And so if we have an anteriorly rotated pelvis, we have to be thinking, okay, is it our hip flexors potentially? Is it coming from the posterior aspect from our erector spinae? What's driving that anterior rotation, right, you guys? So again, these are the deep intrinsic muscles. I forgot the spinalis on the very first slide, but the spinalis, these tight muscles, again, if they're extremely tight, will pull the pelvis into a crazy anterior position. Now, of course, their major role is to keep that pelvis in a neutral position or slightly anteriorly rotated, right? But any tautness to them or any spasm to them, and you get an excessive anterior rotation of the pelvis, and that it becomes a pain generator at the actual spine. Posteriorly, I've already mentioned the glute max, but then you have the deep intrinsics of the hip that can also become extremely taut and either tug the pelvis into a flare position, right? Does that make sense? So they're going to probably play a major role in the inward and outward flare at the pelvis. So again, it becomes important to assess the function and structure of these intrinsics of the hip. On the anterior aspect of the thigh, or anterior aspect of the thigh, we have the quadriceps muscles, in particular the rectus femoris and the sartorius, which are major hip flexors. So if they become tight, again, they're going to tug that pelvis into an anterior position. I'm going to go back to the posterior aspect really quick and mention the hamstrings, because the hamstrings are major causes for a posteriorly rotated pelvis. When they are tight, because they attach to the ischium, when they are tight, they're going to pull that ischium inferior and create a posteriorly rotated pelvis. So they're a major causative factor for a posterior tilt at the actual pelvis itself. Here's another look at the deep intrinsics. Again, because most of the deep intrinsics have that attachment to the sacrum, most often you'll see like flares occurring about the actual ilium itself. I think I put this image on the anatomy PowerPoint and lecture, but again, I want you guys to see what I'm nailing home here is angles of pull, right? We can see how the red muscles, for the most part, if they're taut, they're going to cause an anterior tilt of the pelvis, right? And so that's one of the reasons I'm throwing this back on here, is not to say, okay, yeah, they're pulling in different directions for sure, but these red muscles, the gracilis, the adductors, right, the psoas muscle, they're all, if they're taut, they're going to pull that pelvis, right, into an anteriorly rotated position. On the posterior aspect of that, if we were to flip that pelvis around, if those hamstring muscles are extremely tight, then they're going to tug that pelvis right into a posterior position. So again, knowing that anatomy will help you kind of solve or resolve the dysfunction, and it will kind of drive what you do or how you treat patients clinically. So now we're moving into the patient-reported symptoms, and I'm going to actually take an evidence-based approach to this. So some of this is textbook-driven, but a lot of this is really more research-driven and from different research articles that I've read over the last 5 years. So bear with me on this. So patient-reported symptoms based on the location of pain. So go there, patient-reported symptoms based on the location of pain. So we know sensitivity and specificity, I think, but because it's been so long since we've been in evidence-based practice, let's just take a little bit of time here to review. If we're talking about a highly sensitive test, what we know about a highly sensitive test is that when it's negative, it's a really good test for ruling out pathology. So high on the sensitivity, if it's negative, we're ruling it out. A highly specific test on the opposite end of that, when it's positive, we'll rule in the diagnosis, right? So we have tests that are highly sensitive that we really love to use because we want to rule out big key things. And then we need tests that are highly specific that help us rule in pathologies. So when we look at this table, we're looking at, here's where patients reported pain when they had low back pain. So here are patients reporting groin pain, butt pain, pain on the PSIS or in the PSIS region, and pain with sitting, right? These are the symptoms that patients reported. What we know is that when patients reported pain in the buttock region, right? When they reported pain in the PSIS, or when these were negative, in other words, when they didn't have pain here, then guess what? They didn't have the SI joint issue, right? Does that make sense? So if they didn't report any of these symptoms, then they most often did not have SI joint issue. In other words, we were 80% certain that they didn't have the SI joint. What we do know is that when a patient reported pain with sitting, most often that was associated, 90% of the time, that was associated with an SI joint pathology. So when I'm asking questions, historical questions, right? Notice I didn't give you history questions to ask because we're going to dive through this together right now. When I'm asking history questions, one of the questions I'm going to ask is, okay, do you have butt pain? If the answer is no, more than likely they don't have SI joint issue, right? Does that make sense? Because we're 80% sure if they say no, that they don't have the pathology, right? Do you have pain with sitting? Yes. Oh my gosh. Okay, it's got to be SI joint. Now, this isn't telling us what's causing the SI joint. It's just telling us whether or not it's SI joint related, right? Versus lumbar spine related. Make sense, you guys? I hope so. Okay, so in terms of referral patterns, so SI joint referral patterns, we're looking at this for the referral pattern for SI joint issues. So in other words, they may come in and they may say, honestly, like, where does it hurt? Oh, it hurts right here. It hurts right here, right? And so what we know about patients who reported to the emergency department and actually were diagnosed with SI joint pain, 94% of those patients had pain in the butt region, which seems counterintuitive because the SI joint's way up here, right? Like way up here, but it also generates pain into the gluteal region or the buttock region. And 72% of those patients reported pain in the low back region. But that's such a hard differential, right? Because what else lives in the low back? The lumbar spine, right? So that doesn't necessarily tell us that it's an SI joint pathology. But one of our historical questions should certainly be whether or not they have pain in their glutes or butt region, right? Are you seeing that? I hope so. Okay, in terms of palpable pain, we're going to break this down a little bit. So where are they tender to palpation? Where is an SI joint patient most tender to palpation? Does that make sense? So we're going to spend time in the specificity area because for sensitivity, it's just terrible. There aren't any good sensitivity results. But when we look down at specificity, does that make sense? We're 86% sure that a patient has an SI joint pathology when they're tender to palpation on the sacral sulcus, when they report pain at the PSIS, and if they have some type of groin pain. Are we tracking there? We're 86% sure. So it has to be and, it's not an or, it's an all, okay? So they have to have sacral sulcus tenderness, they have to have some pain on the PSIS, and they have to report some type of groin pain, right? You can tell that if groin pain isn't listed, that the specificity goes down. It's when groin pain is included that the specificity goes up. So groin pain is actually a huge predictor of patients with SI joint pathology. And this wasn't something that I learned in my undergrad program. I always thought it was always isolated to the posterior aspect of the spine. But what we're starting to see is patients with SI joint dysfunction also report pain medially in the groin, and then we also saw report some symptoms going into the gluteal region. So these are things that take you away from the actual focus of the SI joint, but then also what other different things will they report to you in your historical, as you're taking the history part of your interaction with your particular patient. So I hope that as you're thinking through this, historically, I need to ask, do they have butt pain, right? Do they have groin pain? Of course, do they have back pain? Yes. But then as we move into the objective section, the three common areas that I'm going to palpate based on this slide, I'm going to palpate sacral sulcus, right? I'm going to palpate PSIS, which is, right next to the SI joint. And I'm going to actually palpate the groin as well. And your patient may go, why in the heck are you palpating my groin? My SI joint's way back here. Because the research suggests that patients who have SI joint pathologies, sacral sulcus tenderness, PSIS pain, but then also some type of pain in the groin region. Now, by pain in the groin region, I'm referring to that uncomfortable palpation where you're almost at pubic symphysis, so your patient may actually need to report that. But would it stand to reason that a patient could have pain at the pubic symphysis? Yes, right? You guys, if we think about the pelvis and the connectivity, so SI joint is certainly posterior, but if it's moving or if it's shifted, could it cause a shearing at the pubic symphysis and cause pain in the groin region? Absolutely, right, you guys? Okay, so what are some of the causes of SI joint dysfunction? So what are some of the causes? We're going to dive through each of these on different slides, but you can have a traumatic injury, which makes sense, a direct blow to the low back. You fall from a high height and you jar your limb, and that causes shearing at the SI joint. That would be traumatic. You can have a mechanical, which is what we're probably going to spend most of the time talking about, where there's an anterior rotation, which is being driven by maybe the tight erector spinae muscles, the tight hip flexors anteriorly, a posterior rotation, which is most often going to be driven by tight hamstring muscles. You can have slips, right, in the frontal plane, so an upward slip or a downward slip, which is most often, upward slip is most often going to be caused by the quadratus lumborum. You can have a downward slip, which is most often going to be caused by the tensor fasciae lata or tightness in the tensor fasciae lata. And then you can have sacral torsions or inward and outward flares, which most often, when we think about this, are going to be can be caused by the adductor muscle group, or some of the smaller muscles attaching to the actual sacrum itself. Last but not least, we won't spend a whole bunch of time here. You can systemic pathologies can also cause SI joint dysfunction. So things like rheumatoid arthritis or RA, joint infections in particular within the actual SI joint, and then metabolic disorders such as like a gout, a fibromyalgia, right? You guys are getting my point. We're not really built to spend a lot of time in the systemic components of SI joint causes. You'll get that in your general pathology classes. So today I'm going to focus on traumatic, which I kind of already have dove through, but the mechanical part is what you're going to see 80% of the time in the clinical setting. So let's take a look at movement of the sacrum. Okay, so first and foremost, this is cranially, so we're looking at this as it's towards the head. We have caudal, which means it's towards the feet. Does that make sense so far? We have so this would be like kind of like sagittal plane, I guess, for lack of better words. We've got anterior and posterior translation, so the sacrum can translate anteriorly or it can translate posteriorly, about 2 to 4 millimeters. Very small, but certainly can happen. And then last but not least, we can have that coronal plane motion, right? So we can get an anterior rotation or we can have a posterior rotation. So let me say that again. It can shift cranially or caudally, so towards the head or towards the feet. We can have an anterior translation of that sacrum, a posterior translation moving towards the back. We can have an anterior rotation. We can have a posterior rotation. Does that make sense, you guys? And then, of course, we can get around the cranial and caudal translations. We can also get inward and outward flares that can occur through the sacrum. So let's talk specifically about things that can actually happen at the pelvis. So when we're looking at the pelvis, this is an anterior view. This is a posterior view. I think that makes sense. We're talking about flares right now. And when we think about flares, we want to think about the ASIS and the movement of the ASIS. Does that make sense to you all? So an inward flare is one in which the ASIS is moving in towards the umbilicus. And an outward flare is one in which the ASIS is moving away from the umbilicus and or the midline. Does that make sense, you guys? So if we're looking at this here, this ASIS is moving away from the umbilicus. See that arrow? And so then that would be an outward flare. I have to think about this. And then this one is moving in towards the midline. So that would be considered an inward flare of the ilium. So far, so good, you guys. And then you're just seeing that from a posterior perspective. What does that shift look like? Does that make sense? What does that shift look like if we have an outward flare? You can see that PSIS is moving closer to the midline, right? And the inward flare, what does that shift look like, right? It looks like the PSIS is moving away from that sacrum. So think midline. And so one of the things that we'll do in lab is put our finger on the sacrum or the midline and then compare the distance between the PSISs, because a lot of times that's going to tell you if that patient has that outward flare closer to the midline or that inward flare, that PSIS has moved further away from the actual inline itself. So that's one assessment tool that we can use to look at flares of the ilium. Okay. The next type of rotations are the anterior and posterior rotations of the pelvis. I think these are the ones that are probably most intuitive to us as clinicians. What we know in the research literature is that, like, I think it's 85% of anterior rotations most often happen to females. Go figure. But certainly can happen to our male counterparts as well. So when we look at anterior and posterior rotations, the anterior rotation is one in which the ASIS is going to be seated lower, is being pulled lower, and then you have the PSIS being pulled upward or superior, right? Now let's take two scenarios that can occur as a result of one or the other. In a tight hip flexor, the ASIS is being pulled inferior, right? That's going to cause an anterior rotation. Does that make sense? If we have tight erector spinae muscles, right, they're going to do what? They're going to drive the PSIS upwards, which leads to an inferior pull of the ASIS downward, right? So we can have something tugging anteriorly, or we can have something tugging posteriorly, causing an upward movement, right? Either way, what we're seeing is if this is the pelvis, this is what's happening. We have the ASIS moving more inferiorly, and the PSIS being pulled superiorly. On the opposite end of the spectrum is a posteriorly rotated innominate rotation, or a posterior rotation to shorten that. So that's where we have the ASIS being pulled superiorly, right? And then that PSIS being driven inferiorly. But most often, the common cause of a posterior rotation, I would say 90% of the cases, is going to be hamstrings, tight hamstrings, which are tugging on that ischium, which ultimately lead to what? The innominate bone being driven inferiorly. But you certainly could have the case, sorry guys, you certainly could have the case that to where the rectus abdominis or the abdominal muscles are extremely taut, and then they kind of tug on that ASIS and pull it superiorly, causing an inferior drop of the PSIS, right? But most often the causation for a posterior rotation is going to be the hamstring muscle group for sure, right? Ultimately, what I want you guys to see in this image is that with an anterior rotation, that ASIS sits more inferior when we compare it to the other side. And then the opposite happens. In a posterior rotation, that ASIS is sitting more superior. Now, I got asked the question, I don't know who it was, but there was this question of if rotations only happen unilaterally, or do they happen bilaterally? And most often in the clinical setting, we typically see a unilateral rotation or flare or slip, but you certainly could have a patient who has bilateral rotations. You can also have the case where a patient has the opposite rotations, right? So maybe you have an anterior rotation on the, what is this, my left side, and then a posterior rotation on the right side. And so then you get sacral shearing, which would not be good. But most often it's a unilateral rotation that we see at the SI joint occurring. Next, we have up slips and down slips of the pelvis. So just think, essentially, when we see a superior upslip or an upslip, most often what we typically will see is the entire ilium is being shifted superiorly. Does that make sense, you guys? So in this case, which most often this is the case. So 95% of slips occur superiorly or upwardly. So we're going to spend time there. Most often it's as a result of the quadratus lumborum, like an extremely tight quadratus lumborum muscle dragging or pulling that ilium superiorly. So what you see, right, is both ASIS and PSIS are going to be sitting more superior when you compare it to the opposite side. The other thing that you'll see is that one of the things in our palpations is that iliac crest, like when we go to palpate it, you'll see something that looks like this, right? It'll be higher when we compare it to the other side. So one of the things that we typically will see with an upward slip is there's a pubic shearing that happens. So not only do we have the upward flare or the upward shift, but we get this kind of shearing at the pubic bones. And so you can sometimes see, the upward shift can also cause like an irritation at the pubic symphysis and cause irritation or inflammation at the pubic symphysis as well. The other type of movement that we can see is an inferior innominate bone or a down slip. Again, extremely rare. Most often as a result, you can see the TFL. So the TFL is extremely taut, and so it's tugging on the ilium and causing it to drive downwardly. But again, it's extremely rare. Most often what we're going to see in the clinical setting is this right here as a result of a tight QL or quadratus lumborum. So in terms of diagnosis and treatments, what do we do to treat these patients? So first and foremost, to diagnose the pathology, most often, so we do our clinical tests. Is it positive? Is it negative? And then we refer out. Most often an x-ray with measurements will tell us whether or not we have an SI joint issue or dysfunction. You can do a CT scan or an MRI, but those are a lot more costly. So we start with an x-ray. Most often that will give us at least a hint of what's going on. The other way that I've seen it done is in patients who report to the clinic with lots of back pain in the SI joint region. They're reporting that buttock pain, maybe some groin pain, pain at the PSIS, right? Maybe pain in the glute region as well. And so sometimes the physician will go in and do what's called a diagnostic injection, which is what you see here. So they'll inject cortisone into the SI joint. And if that resolves the issue, then we know it's SI joint pathology. If it doesn't solve the issue, then we have to start looking elsewhere. So most often we have to start looking at the lumbar spine because the two pathologies can certainly present very similarly. And so then in terms of actual treatment, it depends on what's causing the pathology. So I want to be clear here that your treatment is truly going to depend on what the dysfunction is. Does that make sense? So you could certainly have a patient who's getting chiropractic care, in particular getting joint manipulations. We might have to stabilize the spine and do some core strengthening exercises or stretching, right? Does that make sense? Or yoga, depending on if it's a tight muscle that's actually causing it. If it's a structural issue, then we have some orthotics, right? Because we're going to need a heel cup of some sort. And then last but not least, we can do some active release technique or muscle energy treatments to help with the tight muscles if we need to. I would say all in all, one of the best treatment approaches that I've seen to SI joint dysfunction actually involves all of these in different ways at different points in time during the actual injury or dysfunction. So evidence-based approach to assessment. What does the research actually tell us? So I'm literally using research articles to help us drive what we're going to do in lab this week. So there's a cluster yielding kind of best assessment that we should use in terms of special tests. And so what are those special tests? We're kind of drive through these. I haven't done this yet, so you guys can let me know if it was a success or a fail. But what we know is that if we do these 4 tests, and we'll go through all of them, but if we do these 4 tests, It's a sensitivity of 82% and a specificity of 88%. So what we're saying is if all 4 of these tests are positive, then we know that the patient has an SI joint dysfunction. Does that make sense, you guys? So the first one is the standing flexion test. So we'll go there. In the standing flexion test, you can see the clinician has his or her hands on both PSISs, and most often what you're going to have the patient do is flex, like bend down and touch their toes. Now, if they do it too fast, you're not going to be able to see PSIS movement. But if they're doing it slow, so it's a slow progression downward to touch their toes, then what you're looking for is what you see here with this yellow arrow. In which direction is the PSIS being driven? So in which direction is the PSIS being driven, but then how much in that particular direction? Well, we know about flexion in general. Remember, in flexion, when we go to flex the spine, we nutate, right? And at about 60 degrees of trunk flexion, what do? We start to counter nutate, right? In a positive standing flexion test, what you'll see is as that patient flexes forward, typically you'll have about the same amount of movement superiorly at the PSIS. And then as they reach about 60 degrees of trunk flexion, the injured side will continue to move cranially, while the uninjured side will either stop or because the sacrum's starting to counter nutate, right? So you'll get more movement superiorly on the side that is dysfunctional. So a positive standing flexion test would be one in which you have the patient flex, you see movement, superior movement of the PSISs, but on the injured side, the PSIS continues to move superiorly. In other words, it's not behaving like it should in flexion, right? When that sacrum starts to counter nutate, it should stop moving superiorly, right? So that's what you're looking for. Increased movement superiorly. Both will move superiorly, but which one is moving more, right? So back to the table we go. The next one is the sitting PSIS palpation test. And in this one, the patient's going to be seated. So there's an assumption here, like if the patient just can't stand, they have pain with weight bearing. So then we progress to the seated PSIS palpation test. In this particular test, as the name implies, the patient is seated on the edge of the table, and the clinician's going to palpate the PSIS, and you're looking for inequality in terms of level and height and also movement, right? So why would this be better than the static standing? I just said it, right, you guys? It's this notion that the patient just can't stand, they have a lot of pain, and so sitting and assessing PSIS movement is a much better way to do that, to remove the pain associated with that particular patient. So a positive sitting PSIS test is going to be similar to a standing, but in a seated position. So when they sit and they flex, right, you would expect PSIS to move superiorly, but again, as they continue to flex in the seated position, does one move more instead of stopping? And if so, then that's the pathological side. So you have the seated, you have the standing flexion test, you have the supine long sitting test. Okay, so in this position, we're going to do it in lab. The patient is supine, so they're lying on their back. The length of the malleoli are compared, okay? So we're going to put our hands on each malleoli and we're going to look, are they at the same level? Is one higher? Is one shorter? Does that make sense? What we know about this is if one leg appears shorter in supine and then lengthens as the patient comes into a long, then we suspect a posteriorly rotated ilium. So let me say that again. If you have the patient lay down and you measure their medial malleoli and then you have them sit up, what you'll see is if the leg was shorter and becomes longer, then that's a posteriorly rotated position. If the opposite happens, so the patient is laying and the leg that's bothering them is longer and they sit up and the leg becomes shorter, then that's an anteriorly rotated position. So let's go ahead and take a look at that test. So if we're here, patient is supine, see how the examiner has their thumb and index finger on each malleoli. So the thumb is on the medial malleolus and then on the lateral malleolus, and same thing here. And then what you're going to see is you're looking at the level of that malleolus, right? So I apologize if I'm looking down, I'm looking at the slide. But we can see that, okay, we're looking at our thumbs equal, is one thumb higher or shorter than another, right? So in this particular case, let's say the injured limb is shorter. And so when they sit up, that limb becomes longer. That's a posteriorly rotated pelvis, right? Let's say, for example, the limb was longer when they were laying and then they sit up and it's shorter. then that's an anteriorly rotated pelvis. So again, we're kind of trying to figure out what's going on at the pelvis. So this is one test to kind of help us figure that out. And then last but not least is the prone knee flexion test. So as the name implies, that patient's going to be on their stomach or in a prone position with the knees flexed. And so then the knees are passively flexed to 90 degrees. And we're looking at kind of leg length. So let's take a look at that image, right? So what we're looking at is, okay, patients in a prone position, we're looking at calcaneal height, essentially, and then they're going to flex their knee, and what we're looking at is what happens here. Is one limb longer than another? Most often that's indicative of a structural leg length discrepancy. Most likely the tibia is either longer and or shorter, depending on what you see in terms of height. Now I want to go back to this table to say that typically this is a clustering of tests. So we should perform all 4 of these tests on the patient if we want to maintain that high specificity. Taking one of these tests in isolation reduces the specificity, which is why they're clustered. In fact, what we know about the standing flexion test is like it has a sensitivity of like 0.17 by itself, and maybe 0.47 for specificity by itself. But when all 4 are done, and if all 4 are positive, then we're 88% certain that the patient has the pathology. Likewise, if all 4 are negative, then we're certain they don't have an SI joint pathology. So again, you have to treat these as a cluster of tests. You have to do all of these tests together to help you strengthen your diagnostic accuracy. All right. Moving forward, we're continuing on with this cluster yielding of best assessment. So the next 4 tests should also be done together in a group. Okay, what we know about this group is it has a high sensitivity. So in other words, the increase in the number of negative tests we get with these 4 tests, the more certain we are that they don't have an SI joint pathology. So the first one is an SI joint compression distraction test. As the name implies, so for this one right here, you're going to be right at that iliac crest, and you're going to be doing a downward and outward movement. Most often what they'll say is that it distracts the SI joint, and it will cause some pain, mainly stretching on the anterior ligaments of the sacrum. So you get a little bit of distraction by pulling apart, but there's a stretching of the ligaments that hold the sacrum together, so it's positive for pain. Here, you're compressing. Do you see? You're right on that. You're right on the SI joint. The patient, this side is the injured side, so the injured side is up. You're pressing on that iliac crest, and you're compressing the SI joint posteriorly, and so that will cause pain. So those are 2 tests. Both should be painful. Okay. The thigh thrust is another test that we use in the clinical setting. So this is the injured side. Patient is in a supine position. Knee is at 90, hip is at 90 degrees, and you are literally, look at me, applying a posterior force through the SI joint. Does that make sense, you guys? So essentially, there's a load being applied right here on top of that patella. It's going to cause a shearing force to the SI joint, and it's going to elicit pain in our patients. The Gainesland's test, patient is supine. Typically will grab the limb that is not injured and hang the limb that is injured off the edge of the table. Now imagine a clinician sitting like right here and applying a downward force to that knee. What are we doing to that SI joint? We're compressing it, right? So we cause pain in the SI joint. So again, these are pain provocating tests essentially. Last but not least is the sacral thrust. So our patient is going to be in a prone position, and you're literally just right on the sacrum and applying a downward force to the sacrum, basically causing a shearing of the posterior ligaments that hold the sacrum together. Again, you're looking for pain. So if we go back to that table, these 5 special tests, or 4, we typically do this in combination, these 4 or 5 special tests, the more that are negative, the more likelihood it is that they don't have the SI joint. We're still 78% certain, if more are positive, that they do, but these aren't the best specific tests to use. Certainly tests to use when we're trying to rule out the SI joint pathology, but again, in clusters, so you have to do these together. So if it were me, I would start with SI joint compression distraction, move into thigh thrust, Gainesland's test, and sacral thrust. You can't skip one of those, because if you do, the diagnostic accuracy of this cluster of tests will decrease itself. Does that make sense, you guys? If not, ask me in lab, okay? Okay, So what is their clinical value, and what other tests do we need to know, right? I've given you like 8 special tests that are crucially important if used in a cluster, but there certainly are other special tests that we'll learn in lab that can be used independently without the clusters, but certainly those 2 clusters are probably the very best that you're actually going to get. One of the special tests that I see being taught a lot in the clinical setting is Patrick Faber's. Patrick Faber's isn't a great clinical test, and here's why. We also learn Patrick Faber's can be used for hip flexor tightness, right? So its diagnostic accuracy just declines because it can be used to assess 2 different pathologies, right? And so you can have a false positive or a false negative or high risk of either of those, but certainly in a patient who has an SI joint pathology, the injured side would go into the figure 4 position, and you're stabilizing the ASIS opposite. You're going to apply downward pressure or force to the knee, and you're looking for pain in the back, right, or in the SI joint region. So certainly a test you can use in the clinical setting. Just know its diagnostic accuracy isn't the greatest. The previous 8 in clusters, of course, are probably the gold standard for assessing SI joint pathologies. The next is the Gillet or Gillett's test. You choose, okay, you guys? So for this test, it's a little bit different than the standing flexion test, because in this test, the patient is actually doing something at the hip versus at the actual trunk. So similar hand positions. Some clinicians will actually do one of 2 things for the offhand. So this is the injured joint because the limb is in the air, and I'll describe that in just a second. But for the offhand, the hand that isn't assessing the injured joint, sometimes the clinicians will put it right on S2 of the sacrum, and others will just put it on the other PSIS. I think the test itself actually calls for the clinician to place the thumb over the S2 joint, so that's how I'll teach it. And I actually like that because the sacrum should be stable, so that hand won't be moving much and you have a comparison side. So that's what I would use, but certainly your clinical preceptors may use the other PSIS as a gauge. It's really up to you. So in a standing position, what you're going to have the patient do is actually flex the knee of the injured side. And what you're looking for is behavior of the PSIS. So when the hip flexes, contrary to the trunk flexing, when the hip flexes and the knee flexes, what you should see on a normal side that isn't dysfunctional is that thumb will drive inferiorly, right? That makes sense. The pubis is shifting out, and so the PSI should shift inferiorly. However, in a dysfunctional SI joint, most often if the patient flexes the hip and the knee, you'll see a superior or a cranial movement, so movement towards the head. That'll be a positive Gillette's test. All right, so how do we treat the SI joint? I've kind of already alluded to this a little bit, but I think now that we're nearing the end of this lecture and you have a better understanding, it depends on the cause, right? So if I taught your gross anatomy course, one of the things that I always teach is this idea of ART, or active release technique, and muscle energy. And I'm a firm believer in this, depending on the muscle that's tight. But I've seen a lot of times that we're using muscle energy or active release techniques over the psoas muscle, and it's really just too deep to really get treatment via ART or muscle energy. But certainly ART and muscle energy can be used for the quadriceps or the erector spinae or the glutes, if that's a causative factor, right? Because those are a lot more superficial. I've seen a combined approach of either joint mobilization from the clinical side at the spine or at the SI joint, or manipulation if you have a doctor of chiropractic or a physical therapist who's been trained to do high velocity thrusts. The biggest key, I think, for us as athletic trainers really lives in the bottom 2 bullet points. So it's flexibility and strengthening. So figuring out what's the causative factor if it's muscular, and trying to attack that from a balance perspective, right? If something's tight, we're going to stretch it. But then we also realize if it's overactive, then the other side is underactive, right? So let's take, for example, if we have a posteriorly rotated pelvis, we know that those hamstrings are lengthened, right? Because it's they're tugging. So we're going to do some soft tissue to kind of loosen them up a little bit. But then at the same time, we have to figure out, what do we do with those hip flexors, right, you guys? Because if the hamstrings are tugging so much on the pelvis, and those hip flexors have to be doing something, right? So do we need to strengthen? Do we need to stretch? What do we need to do? The first thing we need to do is just ask ourselves what's causing the dysfunction, right? We have to figure out what is the dysfunction. Is it an anterior rotation? Is it a posterior rotation? Is it an inward flare? Is it an outward flare? Or is it an upslip? And then we have to figure out, okay, now how do we treat that? From a global perspective, right? Certainly chiropractic treatment is a good treatment, but it's a short-term fix, right? It's going to manipulate the joint, it's going to put it back in its position. But if we have a tight structure, if we have a leg length discrepancy, right? If we have a loose structure, then guess what? As soon as we fix that joint and that patient participates, what's going to happen? It's going to go back to either being it's going to go back to being dysfunctional. So yes, we love chiropractic treatment, but now we have to supplement that with the rehab part, or the rehab component of that. So what are permanent fixes? The permanent fixes are what you decide they are. It's strengthening, it's core stability, it's loosening, it's yoga, it's all of these things combined so that that patient learns how to live in a new normal for that particular joint. So here's the joint mobilization that I see most often in the clinical setting. So joint mobilization. So we're looking at this most often. It's like kind of like a direct approach over the lumbar spine, because we have to adjust or immobilize the spine above and the spine below, right? So we're going to work on lumbar spine. We're also going to be working on the sacrum a little bit, right? And so we can do some joint mobilization. I've also seen hip mobilization. So that seat belt that gets thrown over the hip where we're doing some distraction at the hip joint, it becomes important to play a role in that. And I'm saying mobilization because we as athletic trainers currently cannot perform manipulations, but certainly in conjunction with your chiropractor, he or she is going to perform those high velocity movements that would cause a manip. But for you guys, it's joint mobilization of the lumbar spine, and then certainly some joint mobilization of the SI joint if it's immobile, right? If it's hypermobile, then you don't want to do that. So here are the joint mobilizations of the SI joint and the sacrum. So you can see that that clinician is right over the sacral bone, like kind of, and SI joint, and doing some mobilizations of the sacrum and the SI joint. And you can see these are posterior to anterior joint mobilizations. And the goal, it depends of the treatment. Is it to increase movement? Is it to reduce pain? Because that's going to change the grade of joint mobilization that you're doing. A lot of times we see, do you see how this clinician is lifting that limb up and bringing that hip into extension while mobilizing that SI joint? And that's a fine technique to use as long as the patient doesn't have pain with hip extension, right? Most often with an SI joint, we'll see that the patient has pain with hip extension, so it's not the greatest technique to use. So again, you'll have to pick your treatment based on what the patients are telling you, right, you guys? I hope you see that. And then here's the hip mobilization that has been, I've seen great results with hip mobilizations, right? So you're seeing that seatbelt technique that many of you have already seen in your clinical rotations, but I do recommend it. There are different ways to do it. You can see this clinician has it in between his legs. I most often wrap the seatbelt around kind of my glute region and then use my glutes to drive that hip mobilization. And then there's active release. And I'm just not going to even get on my soapbox about active release of the psoas, but here it is, active release of the psoas. Again, extremely deep muscle. I'm not sure that we'd attack it, but lots of clinicians are using it. So essentially what you're going to do is about 2 finger widths above that ASIS with 4 index fingers. With your 4 fingers, you're going to dive deep into the tissue, and that patient is actively going to flex that hip towards you and away and extend away from you. And the goal is to cause a release of that psoas in an anteriorly rotated pelvis, right, you guys? There's muscle energy. I've seen this done a lot in the clinical setting. So most often for an anteriorly rotated pelvis, that patient is going to be pushing into extension. So in this position, that patient is going to be let me say it this way. The force of the movement is going to be in this direction, right? Patient's going to be pushing against you. The other thing that we often see is that the clinician will also pull at the ischial tube. So this is an up close and kind of personal, right? Like personal type of technique and or treatment, but certainly one that can be done. So the ideal would be pulling that ischium from into a posteriorly rotated position so that it sits in a posteriorly rotated position as opposed to an anteriorly rotated position. I hope that makes sense to you guys. Sometimes I don't know if I'm making sense, but you'll tell me if I don't, okay? So, there is so much to do, right? There's so much that we can do at the SI joint. You guys are probably like, oh, what SI joint? But what's the best question? Like that's what I think this boils down to. It all goes back to your history, right? It all goes back to your evaluation. It all goes back to, okay, which dysfunction am I dealing with? That's the best question. Which dysfunction do I have in front of me? Do I have an anteriorly rotated pelvis? Do I have a posteriorly rotated pelvis? Do I have a superior slip? Do I have a flared pelvis? What pathology do I have in front of me? From there, the question becomes, what things can cause it? And then from there, once you figure out the thing that's causing it, you can treat it, right? And that could be active release technique. That could be putting a heel wedge in. That could be joint mobilizations, or it could be a combination approach, depending on the patient or the student athlete. So I think that's the end of the lecture. It is. I hope that this has been super helpful in terms of understanding the SI joint. There's so much, right? Usually I'm very specific about mechanism of injury, but the cause could be so broad and large. The biggest key component is recognizing what dysfunction you actually have and being able to assess that, right? So in lab, we'll focus on special tasks that help us assess specific dysfunctions. Hope this has been helpful. Congratulations on finishing a very tough and hard and very long fall semester.